So I'm going to begin this session. My name is Tina LeMay. I'm the Manager of Patient Programs at Crohn's and Colitis Canada. I'm very pleased to have the opportunity to moderate today's webinar called More Than a Bathroom Disease with guest speakers Melanie Watson and Richelle Wagner. This is the first of 2 webinars in the Youth Education Series hosted by Crohn's and Colitis Canada and supported by AbbVie. Little background about Crohn's and Colitis Canada. It was established in 1974 by a group of concerned parents of children with Crohn's disease and ulcerative colitis. Now, we are a national charity with more than 65,000 supporters and 80 volunteer groups and chapters across the country. Our mission is to find treatments and cures for Crohn's disease and ulcerative colitis, and to improve the lives and children and adults affected by these diseases. Crohn's and Colitis Canada has funded over $88 million in research to date. That makes us one of the largest funders of Crohn's and colitis research in the world. Just some housekeeping items. All participants are muted so everyone can hear the presentation clearly, and we can record it without audio interference. If you have technical difficulties, as I said before, or would like to ask questions during the webinar, you can type it into the chat box. Simply look to the right side of your screen and you should see a questions field. Regarding your questions, we will make note of them for our speakers to address as many as they can at the end of the presentation. We have allocated an hour for this session. The agenda includes the welcome and introduction, which I'm doing right now. Melanie Watson, our medical expert. Then that will be followed by Richelle Wagner, our patient expert. And we've left 10 minutes at the end for questions and answers that Richelle and Melanie will be able to hopefully answer, and then just the wrap up. So now let's get started by introducing our first speaker, Melanie Watson. Melanie Watson has been practicing as a pediatric nurse practitioner since 2013 at Children's Hospital London Health Sciences Centre. She graduated with her Master's of Nursing, Nurse Practitioner at University of Toronto. She completed her Bachelor of Nursing Science at the University of Toronto and her Bachelor of Sciences Honours Biology at Western University. Melanie quickly honed her practice to focus on children aged 18 and under with Crohn's disease or ulcerative colitis, otherwise known as IBD or inflammatory bowel disease. Melanie provides complex care to patients predominantly through the pediatric outpatient IBD clinic. She manages the outpatient anti-TNF therapies and provides telephone triage for the IBD population. Before becoming a nurse practitioner, she provided care for pediatric inpatients within the areas of hematology and oncology, as well as for general pediatric and adult surgery inpatients. Melanie enjoys teaching and is a lifelong learner. She has a passion for pediatrics and continues to endeavor to cultivate the pediatric IBD program at Children's Hospital. She is a busy wife and a mother of 3. She enjoys spending her spare time traveling with her family. Thank you for being here, Melanie, and here, please go ahead and start your presentation.
Well, thank you so much for that introduction. I'm thrilled to have been given the opportunity to speak with you all this evening. Now, when most people speak about inflammatory bowel disease, they refer to the symptoms that people experience with regards to going to the bathroom. However, what many people don't understand is that IBD is actually a systemic disease. This means that it can affect many parts of your body outside of the digestive tract, and for some, these symptoms can be more debilitating than the actual digestive disease. As such, the aim of my presentation today is to address some of the more common IBD manifestations that occur outside of the bowel. So first I'll attempt to better define extraintestinal manifestations, or EIM is the acronym commonly used. Then I'll highlight several common EIMs in more detail. The topics that I'll explore with you today include joint inflammation, osteoporosis, eye inflammation, anemia, fatigue, abscess, and fistula. Okay, next slide. So I had to start with one of the most famous faces on the internet, except it's not showing here. Next slide. There we go. This guy, the most interesting man in the world. Even he experiences IBD symptoms outside of the digestive tract. As he quotes, "I don't always have IBD symptoms, but when I do, it affects every part of my body." Next slide. So what are EIMs, or extraintestinal manifestations? Well, as I've alluded to, they are specific disease complications known to be associated to IBD that occur. Next slide. So how common are EIMs? Well, about half of the individuals with IBD will experience at least one EIM. About 1/4 of people will have more than one. In fact, if a person has experienced even one EIM, they are more likely to experience additional EIMs over time. The longer you have the disease, the more likely you are to experience an EIM. So are some people with IBD more likely to have EIMs? Well, a few factors appear to impact the likelihood of developing EIMs. And these include perianal Crohn's, disease that's predominantly in the colon, and those individuals that smoke cigarettes tend to have a greater chance of developing EIMs. Next slide. So when during the disease course of IBD do EIMs develop? This graphic is from a study in 2015 and examined the onset of EIMs in individuals with IBD. So there is a lightning bolt there that depicts the IBD diagnosis, and the time illustrates when EIMs occurred. So the authors of this article found that about 1/4 of patients with IBD had EIMs appear before their diagnosis, and about 3/4 of patients had their first EIM after IBD diagnosis. About 30 years after IBD diagnosis, up to 50% of patients had at least one EIM. Next slide. So now that we know how common EIMs are, but what causes them? So the short answer is we're not exactly clear on the cause of EIMs. Some think that the gut mucosa send chemical signals that trigger immune responses at various body sites, and genetics appear to play a role, as some genes tend to have a stronger link to certain EIMs. So next slide. And this is on the first EIM I'll be discussing is one of the most commonly reported extraintestinal complications, and that is aching joints or joint pain. Next slide. Musculoskeletal pain, or pain in the joints, are one of the most common EIMs that individuals with IBD report. About 40% of people with IBD will have joint symptoms at some point and is more commonly experienced in people who have disease in their colon. This can be an additional burden of IBD to many people as it impacts their quality of life and specifically their mobility. So what do we do for people with joint pain? Well, first it's important to understand the different types of joint pain that people experience, as treatment can vary depending on the reason for the joint pain. Next slide. And the next slide, it should be on the differences in joint pain. There we go. One important difference in determining what kind of joint pain one's having is to monitor to see if there is any redness, swelling, or warmth at the affected joint. This helps to determine if the pain is possibly arthritic in nature versus more simply arthralgia, So arthralgias are not unique to IBD, as many people experience arthralgias with other illness. One example of non-IBD arthralgia would be the achy feelings associated with having a virus such as the flu. In IBD, arthralgias tend to coincide with disease activity, meaning that if you're in a flare, you may feel more achy in your joints. This type of joint pain often improves with treatment of IBD and again is not associated with damage to the joint or joint swelling. In contrast, arthritis is usually associated with painful swelling of the joint and often affects mobility. Some find their joints feel stiff, especially in the morning, and that it improves as the day goes on. My last point is that people with arthritis may experience arthralgia, but many people with arthralgia may not have arthritis. Next slide. One type of arthritis I'll discuss today is a rare form of arthritis called ankylosing spondylitis, or AS. This is a severe variation of arthritis and only affects about 2 to 3% of people with IBD. So although it's rare, the reason I'm discussing it in today's Crohn's and Colitis Youth series is because this type of arthritis tends to strike in adolescence and early adulthood, usually before the age of 30. People that have AS present with severe back pain that's usually associated with morning stiffness or pain that gets worse with rest. This is a progressive disease and needs to be followed by a rheumatologist. Biologics may be indicated and usually physiotherapy is recommended to maintain good range of movement. Next slide. In general, there are several treatment options available for arthritis. Often comfort measures such as rest, heat, and physiotherapy for uncomplicated joint pain will help. For more complicated joint pain, anti-inflammatories like Celebrex, NSAIDs, aspirin, and ibuprofen might help. But one caveat to these therapies is that these types of medications can irritate the intestinal lining, exacerbating IBD and even leading to disease flare. So these medications must be used with caution and only if advised by your healthcare provider. Moving on from joint pain, the next topic I'd like to discuss has to do with bones. Next slide. But more about the composition of bones so we don't result in a spine like the one in this picture. Next, that you'll see on the next slide here. So one complication of IBD is osteoporosis, or essentially weakened bones. What is osteoporosis? Well, this term refers to the condition where bones are less dense and therefore have an increased risk of fracturing or breaking. As you can see from the picture, osteoporosis causes the bones to look more porous or filled with holes, making them more prone to breaking. In the general population, next slide, osteoporosis tends to affect older women. However, IBD tends to increase chances of developing this condition regardless of age or sex. Compared to the average population, people with IBD have a 40% higher risk of developing osteoporosis. Furthermore, patients with Crohn's and ulcerative colitis have similar risks of developing osteoporosis. Next slide. Why do people with IBD have an increased risk of osteoporosis? Well, there are several risk factors with IBD that make osteoporosis more likely. First of all, many patients that have been diagnosed with IBD have taken corticosteroids at some point. This is a medication also known as prednisone or prednisolone and usually calms down IBD. Unfortunately, it can also be associated with a decrease in bone density. Many people reduce their physical activity when they're not feeling well, which also plays a role in bone density. When a person is having an active IBD flare, there are cell signals released that cause bone resorption. Finally, there are several dietary limitations that can predispose a person with IBD to osteoporosis. So for instance, many people with IBD report lactose intolerance and therefore avoid dairy, which is a good source of calcium and vitamin D for bone health. In addition, if the individual has undergone a bowel resection, they may not be absorbing their nutrients as well, and this can lead to nutrient deficiencies. Next slide. So how do I know if I have osteoporosis? Well, in order to diagnose osteoporosis, a test called a DEXA scan or bone mineral density is conducted. In adults, osteoporosis is defined as a bone mineral density of 2.5 standard deviations lower than the mean for healthy adults, or a T-score. In children, the relationship between bone mineral density and fracture risk is not well established, and they use a different score called a Z-score. And next slide. So what steps can I take to prevent osteoporosis? Well, ensuring adequate calcium and vitamin D and regular exercise may help. Exercise with impact seems to be important. So for example, not just swimming. If you do require steroids as a treatment for your IBD, supplement with calcium and vitamin D. They recommend not smoking, minimizing alcohol intake, and treating any hormone problems. If severe osteoporosis is diagnosed, referral to a specialist should occur. Finally, it's very encouraging that many patients with IBD tend to have normal bone density once their disease has been well treated and is in remission for 3 years. Next slide. The next EIM I'd like to discuss is eye inflammation in IBD. Eye problems are about the third most common EIM for people with IBD, following problems with joints and skin. It's still a relatively rare complication, occurring in about 2 to 5% of people with IBD. People with Crohn's tend to be more likely to have eye problems when compared to their counterparts with ulcerative colitis. Next slide. What is episcleritis? So the episclera is the thin and invisible layer of tissue that covers the white part or sclera of your eye. If it becomes inflamed, it's called episcleritis. It's the most common eye inflammation associated with IBD. If you look at the diagram of the eye, you can see the episclera is located at the bottom right. Next slide. What if I feel I have episcleritis? Or what will I feel, pardon me, if I have episcleritis? So people that have this condition often notice redness in the white part or sclera of the eye. As you can see from the picture, it looks like a defined region of redness on the white part of the eye. It can feel like a mild burning or irritation to the eye. It's usually only in one eye and does not cause vision changes. This often occurs when your IBD is active. One important note to make about episcleritis is that it does not cause permanent eye damage. It often resolves as the IBD is treated. Comfort measures such as moisturizing drops or cool compresses can help. For more extensive episcleritis, topical steroids are sometimes used. Next slide. Scleritis is another type of eye inflammation that can be associated with IBD. Whereas episcleritis affects the outer lining, scleritis affects the more inner layer as shown in the anatomy picture. Another differentiating feature of scleritis is that it can occur even when your IBD is in remission. Next slide. What symptoms do people with scleritis typically show? Well, most will have severe eye pain, and it can be painful to the touch. Changes in vision occur, and they tend to have photophobia, which means light makes it feel worse. Some note that the sclera appear to be slightly bluish in natural light, which can be a distinguishing feature. This is a very important condition to be treated, as it can lead to permanent eye damage. If you suspect you have scleritis, you should be seen urgently by an ophthalmologist. Treatment usually involves steroids or other immunosuppressants. Recurrences of scleritis may be prevented by ensuring you have adequate IBD disease control. Next slide. So what is uveitis? Well, this is another eye condition, but first you need to understand what the uvea is. And if you look at the picture, The uvea is the middle layer of the eye, and it is made up of 3 parts. Therefore, uveitis occurs when any of those parts become inflamed. Uveitis is less common than the previous eye conditions I discussed, occurring in about 0.5 to 3% of patients with IBD. Women are 4 times more likely to have uveitis, and it occurs alongside joint and skin problems. People that experience uveitis tend to have a chronic form, meaning it comes back. Good IBD control does not seem to impact this condition. Next slide. So what are the symptoms of uveitis? Well, red eye, pain, blurred vision, photophobia or light sensitivity, headaches, and sometimes an irregularly shaped pupil, as you can see in the picture, which will be on the next slide. One distinguishing feature is what they call ciliary flush, where the redness is worse in the center and then gets less intense to the outsides of the eye. The treatment for uveitis, well, you need to go to an ophthalmologist. They are the experts on diagnosing these conditions. If it is found to be uveitis, treatment may involve some form of steroids. Next slide. So moving on from the appearance of bloody eyes to the lack of blood in your bloodstream, the next topic I'd like to discuss is a term many patients with IBD have become familiar with, and this is anemia. And next slide. So anemia is a condition where the blood has a lower number of red blood cells, or hemoglobin, for their age and sex. Hemoglobin is a protein in the red blood cells that is rich in iron and makes blood appear red. It helps the red blood cells carry oxygen to various parts of your body. Therefore, when you have anemia, your body and tissues don't get enough oxygen-rich blood. Next slide. There are several reasons for anemia, such as lack of iron in diet, or if a person has problems absorbing nutrients, such as patients that have chronic diarrhea or have had GI surgery. Other reasons for anemia are surrounding loss of blood, such as bleeding ulcers or bleeding in the intestines. Females that have heavy menstruation may also experience anemia. Finally, micronutrient deficiencies like vitamin B12 and folate can impact anemia. Next slide. What about anemia and IBD? Well, about 1/3 of people with IBD experience anemia, and they may not have any signs or symptoms. Most healthcare providers will ask that you perform regular blood work every 3 to 12 months as a method of monitoring for this condition. The investigations usually include a complete blood count, or CBC, ferritin to assess iron stores, and CRP, which is a marker of inflammation. Next slide. What are symptoms of anemia? So some signs and symptoms include pallor or pale skin, feeling tired, shortness of breath, having a fast heart rate, especially with mild physical exertion, and headaches. Occasionally we see pica, which is an appetite for non-food substances like eating ice, clay, and at times some hair loss. Next slide. How do we treat anemia? Well, most people with IBD can use an oral pill to treat their anemia. There are several different preparations available. In order to have the best absorption, it's best to take iron with vitamin C or orange juice. Try to avoid washing it down with dairy and tea, as these impair absorption. Also, your absorption is diminished with active disease. The most common reason people stop taking their iron is due to GI side effects like constipation, abdominal pain, or mild nausea. And remember that it might take up to 6 months to restore your iron reserves, so continue taking your iron as prescribed by your healthcare practitioner. Next slide. IV iron, also known as as Venofer is indicated for more severe anemia and for people that did not improve with oral iron. It is also given if the healthcare provider needs a quicker response or if there's active IBD disease, because absorption of oral iron is decreased in this scenario. There is a rare risk of anaphylaxis, so this infusion needs to be monitored in a controlled setting like a hospital. Erythropoietin is also used in people that do not respond to IV iron, but it has its own set of risks that I'm not going to get into today. Next slide. Moving along to another commonly reported EIM of IBD is fatigue, and actually that's what some of you might be feeling right now after listening to me speak. Next slide. So it seems silly to define fatigue, as we all think that we've experienced this feeling. However, fatigue is not the same as being tired. Fatigue tends to be overwhelming tiredness or even exhaustion that isn't made better by rest or sleep. People with IBD report that it can be very unpredictable, often coming on suddenly. Next slide. Fatigue is very common for individuals with IBD, affecting up to 75% of patients. This negatively affects many aspects of life. Even when patients are in remission, many still suffer from ongoing fatigue, and we really don't understand why. So fatigue is considered to be a subjective complaint, which means that there's no blood test or real way to measure the fatigue. So this area of IBD is not well understood or well studied. Likely one of the reasons this topic isn't well understood is because it's difficult to measure, and in fact there are more than 7 different fatigue scales, making it difficult to standardize. Next slide. There are several thoughts as to why patients with IBD tend to be at greater risk of experiencing fatigue. When most people have a cold or the flu, they feel more tired. Similarly, in an IBD flare, people feel fatigue as it's the body's response to inflammation and illness. Other reasons people feel fatigue with IBD may be due to disturbed sleep, especially if you have to get up to go to the bathroom at night. Pain, anxiety, or worry can all lead to fatigue. Anemia, vitamin deficiencies, or even some of the medications we use in IBD can cause fatigue. However, in some cases, there is no explanation. Next slide. Fatigue can affect almost all aspects of one's life. So some have difficulty participating in physical activity or even routine chores. Many report difficulty with concentration and memory, which may impact school and work performance. Others withdraw from social activities and may find it difficult to do things like planning trips or participate in their hobbies. This can lead to feelings of isolation, anger, or even depression. Some find fatigue negatively impacts their relationships with loved ones and friends and may feel misunderstood as they don't look sick. Next slide. So if you think you are experiencing fatigue, it's important to tell your healthcare provider. They may want to look for a cause of your fatigue so that it can be treated. Next slide. So what steps can I take to improve fatigue? Well, it may seem counterintuitive, but a gradual increase in exercise may improve fatigue. Individuals need to start gradually, as overdoing it may result in more fatigue. A nutritious diet that is balanced can improve fatigue. Many IBD centers have access to a dietitian to ensure you're getting all of the nutrients you require. Some find taking regular breaks and having good sleep habits can help. Others vary their work schedule and use alternative therapies like yoga to aid in their feelings of fatigue. Next slide. My final topic today is regarding fistulas and abscesses, or sometimes you may hear this referred to as perianal disease. And this occurs in about 1/3 of our IBD patients. Next slide. Fistulas are essentially deep sores in the intestines that end up breaking through the wall of the intestine and create a tunnel to different parts of the body. Depending on where the sore is located, it may penetrate to nearby structures like the bladder, the vagina, or even the skin. Fistulas occur only in Crohn's disease because it tends to have transmural inflammation, which means that it affects the entire wall of the intestine and sometimes can break through the wall. In contrast, ulcerative colitis tends to be a more superficial inflammation, meaning it just affects the lining of the colon and therefore fistulas don't occur. Treatment of fistulas can involve antibiotics, surgery, or sometimes using cetons, which you'll see in a few slides, and biologics. Next slide. Our last EIM to discuss today is abscesses. So abscesses are basically pockets of pus. The picture in the slide will show a perianal abscess. Perianal abscesses are often very painful and tender and may appear like a boil or big sore pimple. Some people get a fever with them and some people don't. Treatment usually involves some form of antibiotics and may or may not involve lancing, where a small cut is placed to relieve the pus and pressure. Once it's drained, the symptoms often resolve. So in summary, IBD is a complex health issue that affects many components of one's health outside of the gut. With an increased awareness of complications that may occur in conjunction with IBD, my hope is that you discuss any potential concerns with your healthcare provider and keep in mind that many of these complications are treatable. And that's the end of my presentation. Thanks for your attention.
Thank you, Melanie, for that very informative presentation. I apologize to the audience that Melanie was going in and out of the speaker. Hopefully with Richelle's, that will be dealt with by speaking. Richelle, just speak directly into the phone rather than on speakerphone. Now to introduce Richelle Wagner, currently a graduate of the University of Alberta, Augustana faculty. Richelle Wagner was diagnosed with ulcerative colitis at the age of 13. Richelle had maintained a healthy lifestyle, traveling, volunteering, and playing many sports, including college basketball for the University of Alberta's Augustana faculty. During her athletic career, Richelle was on varying dosages of prednisone, Imuran, and Asacol, as well as having to make 2-hour trips to the University Hospital once a week for iron fusions. Despite this, she was still able to play and was a first-team all-conference player for the Women's ACAC League in 2014, an academic all-Canadian, and the university's Female Athlete of the Year of the university for her final season in 2014. Richelle was able to manage her symptoms through fitness, healthy eating, and lots of sleep. She's currently taking a year off and preparing to travel to Greece and Portugal for 4 months before applying for a master's and PhD program in clinical psychology. So, Richelle, please take it away.
Awesome. Thank you so much for having me. Yeah, so I'm here to talk about my experience with some of these issues that we're facing. And one of the first ones that I had trouble with was anemia. So in my 4th year of university, I struggled a lot with anemia. During that time, I was going to university in Camrose, and I was playing on the women's basketball team. I had 2 practices a day, Monday to Thursday, so I had 2 hours in the morning, and then I'd have a 2-hour session in the evening. And on Fridays and Saturdays, I would have practices as well as games, so it took about 6 hours of my time during those games. During this time, I was also taking 4 classes per semester. During this time, I was losing a lot of blood with my UC, and I was struggling with vitamin B12 and my folate levels. So a lot of the symptoms I was struggling with was easy fatigue, which was a loss of energy during my practices and during my classes during the day. I had a rapid heart rate when I was exercising, and I was struggling with headaches. Dizziness was a big problem for me, and I had a lot of leg cramps while I was participating in my sports. So some of the complications that came with that ended up having to put me on iron pills. So I first went to that, but the iron pills actually really agitated my intestine, and it ended up having to cause me to go to the intravenous iron infusions. So during that time, I had to drive an hour and a half to 2 hours just to get to the hospital. And then I would have about, depending on how I responded to the infusion, I would be there for about roughly 2 hours. And then I would have to drive about 2 hours back to school. So during that time, it was once a week. I had 4 classes. I had basketball practice twice a day. So I somehow had to make it work. These infusions weren't bad. Once you get used to them, they're honestly not too bad, and you'll see a response in your body fairly quick, within about a week or two, personally for me. My arm was where I kind of got it done, and it felt sore, and the bruising may look bad depending on how much iron you're having infused, but overall, it's not too bad. So how I managed some of these symptoms, first of all, I had to be very patient with myself. I couldn't take on too much, so I know it sounds like I did because I had basketball and I had school, but homework had to wait until I was done, sometimes my 30-minute power nap, or I had to tell my coach that, hey, maybe I couldn't come to practice super early. I had to rest up a little bit. So communication for me personally with people around me helped a lot with that. And another thing that's very important is I had to know when to take a break, and I had to be very cognizant of what I was eating. So what I was putting in my body had a huge influence on how I was feeling. Personally, for me, I felt that sugar was not really good, so the less amount of sugar was better for me. So the next thing that came with that was fatigue. So like Melanie said earlier, very different than what people think. It's not necessarily solved through sleep. So my experience with fatigue was that I struggled with fatigue since I was diagnosed when I was 13. So I had a bad flare-up in high school, and then I had another bad flare-up in college. If I didn't get 7 to 9 hours of sleep, the next day was really tough. It really affected me. Even though sleep wasn't a huge factor, it still aided in me kind of competing against this fatigue I was having. So some of the complications I was having during this time was I couldn't pay attention in class. This had to do with issues of also retaining information, and I started struggling, and you could see it in my marks. I also was struggling just getting homework done once I was done school. So by the time the day ended, I was beat. And I had to know when to take my breaks and kind of be patient. And if I couldn't get my homework done, I had to maybe get up the next day and finish it or stuff like that. With my athletics, I started struggling in practice. And by the end of the practice, I was done. Coach was getting frustrated. And I started developing many injuries because of this, because I wasn't able to strong enough to compete at the level that I was playing at. So how did I manage this? For athletics specifically, like I said, I slept a lot. I made sure, though, to never sleep in too long, or else the day was kind of shot for me, and it kind of made me more tired. Although, like we talked about before, sleep is not always the best solution. The main thing that I had to learn was that I was smart with my time while balancing everything in my life. So one of the main things was that when I came to school, I didn't have a coffee also. That was a really big thing. But when I got to school, I got my homework done, I did my classes, and if I had, let's say, 20 minutes between a class, I had to be smart about it, and maybe I would start some of the homework that was due for the next day. This allowed me to not have such a huge load of homework by the end of the day when I was already so tired. Another thing, right before I was sleeping, I didn't look at social media at least an hour before bed. So whether that was on my phone or the computer, or even if I was watching a movie, I did my best to stay away from anything that would interfere with my sleep, because that was such a huge factor in the next day, competing against the fatigue I was already struggling with. School, time management is everything, like I said. You have to take your breaks and know when to do homework and when not to do homework. Another big thing for me was that I had to start on assignments early. So whether you're in high school or whether you're at work or whether you're at a college level, any projects that are coming up, start on them early. So whenever you have a break or whatever, just start kind of tearing away at that assignment, and it'll help you in the future. During November, for college students, they know a lot, is that they have a lot of exams and they have a lot of projects coming about during that time. This can be very stressful. And during this time, you'll want to pull all these all-nighters. But unfortunately, during this time, that's the best time for a flare-up. So counteract this from the very beginning, start these projects early, and that way when you come to it, you don't have a lot on your plate that you can't handle, and that's going to cause you more issues. Another big thing is to talk to your profs ahead of time, or people in your life, or your boss, or whatever. Let them know about your Crohn's or colitis, and discuss with them the options regarding extensions on projects, assignments, exam. This way, if you get sick, they'll be prepared and you will be more likely granted extension. I think a lot of people don't think, or they're embarrassed about telling people that they have this condition. But if you're upfront about it right away, in the future you'll be more likely to have an easier progress into how you're dealing with people in your life to help you out with these situations, and you won't feel so bad if it's a few days before you get really, really sick and you're not able to complete it. And then that way the prof may or may not trust you in the future because you came at it last second. This way you build a trust rate over this relationship right from the beginning, and you're able to proceed with your studies in a more confident manner for yourself, so it's less stress. So osteoporosis, I personally have not been diagnosed with osteoporosis, but since I was diagnosed with UC when I was 13 years old, I didn't actually get my period until I was 19. I really struggled to gain weight while I was going through puberty, and as a result, my bones haven't always been the strongest. For most of my grade 11 year specifically, and a little of my grade 12 year, I struggled with a major flare-up, and therefore starting my university basketball career, I had just been on prednisone on and off for the past 2 years. So this became very problematic for me. Complications were when I first entered university basketball, I was already struggling with fatigue, amongst other things. And 3 months into my first year playing, I ended up actually fracturing my right foot just by running on it. So this was a bone fracture that occurred more easily than expected. No one else on my team experienced this, so it was not a common thing of overtraining. It was just my bones not really holding up. This then caused me even more issues that I didn't take care of because it led to hip issues. And then I actually ended up blowing out both of my ACLs in the future because I didn't take care of this one injury. So management. Going forward, I was way more careful after I rehabbed my foot and how I trained, and I also consumed way more calcium. So like Melanie said, I am actually currently lactose and gluten intolerant, so I have to be smarter with my eating decisions now. But broccoli was my best friend in college, as well as lactose-free milk. As an athlete, I also focused on less hard impacting training than my teammates. So, for example, if anybody wants to pursue sports and they're really scared to attempt it because of some of their symptoms, just be very aware of the cause, like of osteoporosis and how it may impact you, even if you haven't been diagnosed, because you do have less nutrients coming into your body, right? So when I was training, I had to be very diverse with it. So when my teammates maybe were doing a track run on the ground, I would go swimming, or I would go biking, and I would do multiple things that were more diverse that could help my body. Furthermore, it is very important to talk about the fact that you need to work out while you have this disease. I know we don't want to, and I know we don't feel good and we're sick and stuff like that, but it is so important, especially with osteoporosis, with weight training, and it's important to strengthen your bones. So strengthening your muscles around the bones also allows for more stability, which I struggled with while playing basketball. And stretching is so important for your body, and especially for me during this time that I was having so many injuries. So resources. While you're going through college and high school and you're going through life, there's so many resources that we forget to utilize. So specifically in school, for me, I didn't find this out until I had a bad flare-up in my second year. At the U of A, it's SSDS, which is Student Accessibility Services, and they help you with exam and assignment accommodations. So sometimes we forget that it's okay to ask for help. And there's a big, sometimes, stigma around these things, and we just should not be embarrassed to utilize it. So personally for me, I struggled in my second year, and I was very sick, and I was missing a lot of classes. So someone kind of brought it up to me that SSDS actually could help me, which I did not think they offered. I thought it was people that were struggling with disabilities or test anxiety or other complications. So I went there, and it was amazing. So I was struggling, and I couldn't come to class, and I was missing actually some midterms. So what they did is I got a sheet of paper, and then I went to my prof, and we talked about it. They signed it. They understood what was going on in my life and how that may not always fit with my school schedule. And in the future, I didn't have any stress going into exams, because I knew that, let's say I was stressed out about the exam myself, and it caused me to have a flare-up, or I just started not feeling good. I knew that if I couldn't make it to the exam, I would not lose any marks, and I would not be penalized for it. These guys took care of me, and it was an amazing experience that I would recommend for all patients. Because even if you're in remission and you think, oh, no, I'm fine, I don't need this, this could come out of time very useful. So you might be in remission, and then suddenly you're going through school, you have a lot of stress, you're not sleeping enough, you're kind of pounding in the caffeine, you're doing things that maybe aren't the best for your body, trying to keep up with school, and you develop a flare-up. This could save you so much during that time. And it is very important, like I said, to not be embarrassed to use these kind of things. These things are important, and no one has, if you are embarrassed, no one needs to know about them, right? Just between you and your teacher. Your next resource is your teachers, which goes straight along with school and the SSCS program. The more they know about what you're going through, the more they're willing to help you out in projects, in exams, anything to help you succeed. Teachers are very accommodating, especially when they know that you want to succeed. Another resource is classmates. So you're missing a lot of classes, you're not feeling good. Classmates will help you out so much by taking notes, or telling you, reminding you that you have a project, or giving you a heads up on maybe a pop quiz the next class. Classmates are very important and will help you succeed while you're struggling with your health. Friends, family, and partners are also crucial. Keep these people close to you during school, during work, during athletic sports, whatever you're doing. These people are very important to you, because you can be in a very stressful time, and keeping these people there to be patient with you and to give you a positive and less stressful environment will help you go so much farther. Personally, for me, it helped me substantially in basketball, and then as well as in school when I was going through finals. These people really, really helped me and benefited me in the long run. Coaches, coaches were huge. So as a college and university athlete, I really didn't want to involve my coach, because I wanted them to know that I was tough and I could handle anything that they threw at me. But honestly, that is not realistic. With athletics specifically, my immune system is not very great. I'm on Imuran, and I'm very susceptible to any germ that comes my way. So playing sports, I was always touching balls, and I was high-fiving people, and the germs were getting on me, and I was getting strep throat, for example, 3 times in 3 months, which really, really impacted my athletic performance. So be completely translucent with your coaches. Let them know right from the beginning, hey, I have this. These are the things that could happen. I want to work with you. So that as I'm going through this process. So yeah, and then I'm going actually traveling soon. So that's another thing is, even if you have all these symptoms, know that you can push through and you can go into the future knowing that you can control these symptoms in the best way you can. You can live with the system and you can succeed with these symptoms. It's just knowing your body and knowing how you personally can handle and what works for you. So yeah, that's my experience. If anybody has any questions, feel free to ask away. Thank you.
Yes, thank you, Richelle, for your perspective. That was wonderful, very helpful indeed. Just to move on and get it going, we're going to go into some of the questions that have been asked throughout the presentation. Richelle, since you're on the line there, one question was, how do you motivate yourself when you have fatigue?
When I have fatigue, the best way is I actually spoke with my parents and I spoke with my teammates a lot. So, like I said, translucent with my coach, but I should have also mentioned that it was my teammates that helped motivate me as well. When I was feeling down and I just did not have the energy like that, I would talk to people and they would let me know that, hey, they got my back and that I just need to keep pushing. So during those times, I looked to inspiration through people, and I also looked to inspiration through music. That was really huge, and it was a very self-motivating process while still leaning on the closest people in my life to help me out whenever I kind of lacked in that area. So if anybody's struggling, honestly, give someone talking to, ask for a pump up, or listen to a song, or like go read something inspirational. Sometimes you need that extra push. And during that time, never feel embarrassed to go and ask for it. That's something really important, and yeah, it helped me succeed personally.
Was it hard? One of the questions was it hard explaining your fatigue at the beginning to others?
It was embarrassing. It wasn't just hard, it was very embarrassing. Being on a team with a lot of very physically active people who are doing all the same things as me. They're working out the same or harder sometimes and doing over and beyond things that I wasn't. I think it's hard to speak those words, hey, I'm fatigued, because you don't want to feel like the other person, making the other person feel like, oh, well, I'm doing it too, like, why can't you? So right. It was very embarrassing, and it then led me to have to explain myself with my disease. But you know what? That brings everybody closer. So fatigue comes along with osteoporosis, and that's something you just have to accept, and people have to accept. So once you accept it yourself and you're able to share it with everybody else, most people are very understanding. And it's just kind of jumping over that first hurdle that can help.
Did anybody ever think you were faking it?
Oh, yes. Questions? Yes. Yeah, many times. Like I said, visually, you would never tell. I did not have bags under my eyes. I was not very pale. I was not really displaying any symptoms. I had a few people on my team specifically kind of get frustrated with me, and that's fine. I just had to have a one-on-one talk with them and explain myself, and they came to understanding and ended up being a stronger relation because of that. But if someone doesn't understand, you know, that's on them. You cannot take that personally, and you have to focus on yourself and stay motivated and know that this is the path that you're taking, and to be patient with yourself if you can't do everything.
Well, thanks very much, Richelle. That was that's very helpful. Questions for Melanie. Melanie, are you there?
I am. Can you hear me?
Yes, I can.
Okay.
Anybody else?
Can everyone hear me? I switched from using the internet for my microphone to my phone, so I'm hoping it's more clear.
Yes, it sounds it. Thank you very much. So one of the questions was, I've noticed that my hair has started to fall out. Could that be a side effect of medications, or is that just related to Crohn's disease?
Well, so that's a good question, and it's actually a common one, and it's not an easy answer. So there's many different reasons why people experience hair loss. So one of them can be because actually when your body is sick, your hair is a protein, and therefore you're lacking good nutrition a lot of the time because you're sick, and so as a result, it's often a delayed effect, but it can just happen as a result of Crohn's. But another reason that hair loss can happen is side effect of medication. So things like biologics. They've been known to have some. But it can also be nutrient deficiencies. So, for instance, having low iron, this can also be a reason for hair loss. So it often is reversible. You can grow back, and people will see these kind of like really short hairs growing out of their hairline, and that's often the hairs starting to replenish again as the disease gets under control again. But I guess the short answer is it may be the Crohn's, it may be medication. Best thing to do is to raise it with your healthcare provider and see if they can help tease that out.
Thank you. That's helpful. So another question is, any links between Crohn's or colitis and psoriasis?
Yes. So psoriasis is also an autoimmune disease. So just like ulcerative colitis and Crohn's disease is also an autoimmune disease. Some people it can go hand in hand, or some people, there's another condition called eczema that often coincides with this autoimmune process. Now, psoriasis can also be a side effect of some of the medications that we use. So again, for biologics, sometimes people will have that as a side effect. However, for some people, biologic is actually a treatment for psoriasis. So yes, it is kind of all under the same umbrella, but to get at the real, to have an actual diagnosis of psoriasis, it's usually followed by dermatology, and sometimes people can use topicals to treat it, but yes, it can go hand in hand.
That's great. Another question, why can it take a while to heal abscesses? And secondly, why don't they heal sometimes?
So it depends. So there's different types of abscesses. It depends on where they are and how big they are and the complexity of them. So sometimes they can heal quite quickly just with oral antibiotics. Other times, if it's deeper, or sometimes they'll say like it's almost like it's confined, so it's not draining. That makes it harder to get at, and some people actually require IV antibiotics for it. So the challenge with inflammatory bowel disease is often the medications that we're using to treat the inflammatory bowel disease involve immunosuppression. Meanwhile, abscesses are infection that your body is trying to fight off, but meanwhile we're trying to keep this balance of keeping your immune system suppressed, and that can make it harder to fight off these abscesses. So if it continues to be a problem, usually you need to escalate treatment, or again talk to your healthcare provider about why is it not resolving.
Thank you. One last question. How long after diagnosis would you expect to get symptoms?
How long after diagnosis do you get symptoms, did you say?
Yes, that's correct.
So, you know what, it varies with each individual. A lot of symptoms, like just in general symptoms, people will have subtle signs before diagnosis. In terms of after diagnosis, it really is dependent on the severity of disease, which disease it is, where your disease is located. So, for instance, some people with small bowel Crohn's disease don't have a lot of symptoms other than maybe some vague abdominal pain, whereas people with ulcerative colitis, they tend to, they're more likely to get the sort of bloody diarrhea, but it varies essentially based on your diagnosis, the location of your disease, and the severity of your disease. So there's no just one time point.
Okay, well, thank you. All right, so I think we're going to wrap up. Thank you again, Melanie and Richelle, for presenting today. We'll be following up with all of the participants by email to get your feedback and any suggestions you may have for future topics. We'll also be sending you a link to the recording of today's webinar. And again, we apologize for some of the technical difficulties in the beginning. And just so you know, we have another upcoming webinar on October 20th presenting on the topic, Looking Ahead, the Future of IBD Treatment and What It Means for You, with expert Dr. Bressler. Registration for the webinar is still available. So for more information, please go to crohnsandcolitis.ca. This concludes our webinar today, and thank you for participating.